Hi, my name is Brian Lee, and I'm one of the shoulder elbow surgeons at Curlin Job. I have the privilege of speaking today on the indications and biomechanics for shoulder arthroplasty, anatomic and reverse. And I want to just thank everybody for tuning in. Hopefully, this is going to be educational. And as somebody that's very a big proponent of physical therapy for my patients, I hope that this can be the start of a dialogue to help kind of optimize the treatment of our patients going forward. So as a brief outline for the talk today, I wanted to first talk about normal glenohumeral and shoulder anatomy and function. From that, we'll get a sense of how the anatomic replacement, can really work well, the goals of the surgery on the humeral side and the glenoid side, and then delve into reverse shoulder replacement, kind of the biomechanics, how it works, and the evolution of the prosthesis. So when you look at anatomic total shoulder replacement, really the goal is to restore the native anatomy of the shoulder. So, when we look at the shoulder, much of the motion comes from the glenohumeral joint or the ball and socket. And during an anatomic shoulder replacement, a lot of what we're trying to do is optimize and recreate the native anatomy that the patient had when they were having a well-functioning shoulder. So when we look at the shoulder itself, there have been multiple kind of cadaveric studies and radiographic studies looking at normal morphology of the proximal humerus. So starting on the humeral side, the humeral head has an average radius of curvature of 24 millimeters and an average thickness of 19 millimeters. Now there's a lot of variation there, but there does seem to be a linear correlation between increasing size as far as the diameter of the humeral head and the thickness. And that's something that we try to recreate during surgery and is reflected in the availability of our prosthesis options. The center of the head is actually quite spherical and the periphery is elliptical, so it's not a perfect circle. But when we're trying to look at radiographs, really the best way that we have to kind of recreate things is to look at perfect circles, especially on the coronal view as shown on the left here. Of note, the humeral head typically is on top of the greater tuberosity by about 6 to 8 millimeters. That allows for kind of that extra range of motion when you clear the head, so that the tuberosity doesn't start abutting against the acromion at the top of the range of motion. Finally, there's an inclination of the neck of the humerus or anatomic neck where the articular margin becomes bony, and that is about 135 degrees relative to the shaft. With regard to the humeral head, if you look at the position of the articular surface compared with the axis of the elbow from the medial epicondyle to the lateral epicondyle, the average is about 18 degrees of retroversion. But based on cadaveric studies, there's a wide range of variety between the position of that. So it can be anywhere from 7 degrees anaverted to 48 degrees retroverted. And that's something that we're trying to look at during surgery and trying to reconstruct accurately. As far as the glenoid is actually pear-shaped, so it's not a circular socket. The inferior portion of the glenoid is larger than the superior portion. There's about 4 centimeters of distance from the top to the bottom and about 3 centimeters from the anterior to posterior direction. There's on average a 4 degrees superior inclination of the glenoid, and about 1 degree of retroversion or kind of pointing backwards on the native glenoid. Now, as far as the rotator cuff, very important group of muscles that surround the shoulder. And you often think of athletes, overhead throwers, and having problems with rotator cuff tears, but especially in my practice, it's the older patient who likes playing pickleball or golfing or even gardening in their free time who really needs their rotator cuff to have an optimal shoulder. So the rotator cuff, again, is a group of 4 muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis. These surround the ball, and they're stabilizers of the glenohumeral joint. Not only do they help to elevate and rotate the arm, especially at the beginning or early humeral ranges of motion, but they compress and center the ball against the socket and allow the big deltoid muscle to fire. So if you look at the deltoid here, the vector of the force is going to be superior. So you really rely on the rotator cuff to kind of keep the ball centered against the socket and allow optimal motion of the shoulder. And we'll get into what happens if you don't have sufficient rotator cuff to battle the deltoid forces. Finally, there's an actual mismatch between the radius of curvature of the ball compared to the socket. So the glenoid radius of curvature is about 2 millimeters greater, or essentially it's flatter than the humeral head. And what that allows for is a little bit of play between the ball and the socket, especially at that end range of motion. So instead of being perfectly matched against the socket, there's a little bit of play. And that little bit of play allows for a little bit of shifting of the ball within the motion and basically optimal motion, or getting more range of motion than a constrained uh, matched radius of curvature situation. So as far as anatomic total shoulder arthroplasty design, the first shoulder replacement um, was really performed actually in 1893 by a Parisian surgeon. This was done for a patient with tuberculosis, and the actual prosthesis is shown on the left here. So it was I believe, a platinum humeral stem, a rubber ball that was wired to the stem, and then the ball was also wired to the glenoid to keep it together. Unfortunately, this didn't last very long. And it wasn't until Dr. Neer in the 50s designed a monoblock implant. He first used these basically hemiarthroplasties for patients with complex humeral fractures, and eventually evolved it and designed the first kind of modern shoulder replacement. So again, the first kind of generation of shoulder replacement was a monoblock. So it came in one size head, and it went in the the direction that it was going to fit in. The second generation brought about basically modularity of the head, or different head options for the given stem. So while this was an improvement on the first generation, the diagram on the right shows basically the head kind of positions, uh, and basically the ability to recreate the position of the head. But you can see that there's discrepancy between the native head, which is the blue kind of diagram. And so it wasn't until the third generation where shoulder arthroplasty really made a leap forward. With the third generation, the goal was to truly kind of recreate the anatomy of the shoulder. This was accomplished by not only continuing with the modularity of the head and adding offsets to the head, or eccentricity, but also allowing for changes in the inclination of the head or the neck, and also changes in version. So with this design, as you can see on the bottom right here, we were able to very accurately have options to recreate the native anatomy. We've now moved on to what we deem the fourth generation, um, kind of continuing on with the previous principles, but now allowing for convertibility. So the same stem can be used for an anatomic or reverse shoulder replacement. And we also have stemless or canal sparing options, where you have this small nucleus that allows basically to have basically a total shoulder at this point, without violating the humeral canal. Um, and just so is this available in reverse? That is kind of coming down the pipeline, and we'll see kind of where that goes. So again, the goal is to restore the anatomy. So this is a kind of a cool picture where in box A and D, you can see basically two different proximal humeruses with different head sizes, neck angles. And in the following boxes, you can see how you can kind of recreate each anatomic picture using different head sizes, or head cuts, and different neck inclinations. So during surgery, we're constantly kind of trying to best kind of recreate the anatomy. So this is one of my cases from a couple of weeks ago, where after you make the anatomic head resection, you're looking at, I actually will take the head itself and try to size that to the kind of the prosthetic head that I'm going to use. Um, the stemless replacement works very nicely if you have good bone proximally there after that head has been cut. And then, of course, you can see the plastic socket, which is invisible on the x-ray, but there's that center little metallic marker within the center peg, which lets you know where it is. So the problems with total shoulder arthroplasty, biomechanically, they really arise from rotator cuff insufficiency or improper sizing. So rotator cuff insufficiency can come about preoperatively and postoperatively. So preoperatively, if a patient has a rotator cuff tear that's not repairable, they are generally not considered a candidate for an anatomic shoulder replacement, and are likely going to do better with a reverse replacement. And we'll get into why in a little bit. But As far as kind of how we approach the shoulder, generally shoulder replacement is done through a deltopectoral approach. So um, most surgeons will do something with the subscapularis to get into the shoulder and perform the work at the glenohumeral joint, and then repair the subscapularis after. So there are really three different techniques to get into the shoulder joint. One way to do it is through a peel, where you basically will resect or cut the subscapularis from that bone, that little projection called the lesser tuberosity. You'll retract that subscapularis as seen kind of in that lower picture there, do the work and do the replacement, and then sew that tendon back to the bone. So that's the peel. On that upper picture, if you look at it again, with a tenotomy, you actually cut the tendon. So again, you're going to cut that tendon, retract the tendon medially, perform the shoulder replacement, and then repair tendon back to tendon. Finally, there's a lesser tuberosity osteotomy, where you're actually cutting the bone that that subscapularis attaches to. You're taking that piece of bone with the tendon attached to it, retracting it medially, and then doing the shoulder replacement and repairing that back down. And that's my preferred method. I have some pictures here. So on the first picture on the left here, you can see kind of to the right of that shaded area. Hopefully my arrow shows up here. That's going to be your lesser tuberosity and your subscapularis projecting medially that way. The second picture shows after the osteotomy has been performed. So you have a nice healthy piece of bone with a nice tendon attached to it. This third picture shows after the head has been implanted. These are sutures that are passed through the basically bicipital groove or biceps groove and through the osteotomy, and are going to be later used to repair the lesser tuberosity. Okay. So this is the repaired construct, and you can see the nice kind of stability of that repair that you get, along with some nice soundtrack music. So as far as improper sizing, it's very easy, especially for somebody that doesn't do a lot of shoulder replacement or is very early in their kind of practice, to use a bigger head than a patient needs. So with a bigger head, it kind of gives you a little bit more freedom as far as avoiding instability or dislocation, which is obviously the big complication that you want to avoid. But it doesn't do the patient favors, because these are the patients that are going to be very stiff, and they're more likely to have rotator cuff problems. So on this picture on the bottom, you can see this head is too big. And so the rotator cuff is overtensioned, and it's going to be at risk for tearing, not only on the supraspinatus, but more importantly on the subscapularis. If you have failure of your subscapularis repair, then you're really going to have problems, as the subscapularis is the most important rotator cuff muscle. So continuing on with kind of problems with shoulder replacement, loosening of the glenoid is the most common kind of biomechanical complication that we're going to encounter as far as doing shoulder replacements. When you have essentially a rotator cuff tear, especially of the subscapularis, you lose that stabilizing force of the ball against the socket. So with that, will essentially get kind of teetering of that ball because of the instability against that socket, and cause that socket to basically back out. It's been dubbed the rocking horse phenomenon, and has led to early kind of failures of shoulder replacement. Humeral loosening is a very low kind of incidence. It's less than 1% at 5 years based on most studies, and is often actually associated with glenoid loosening, kind of causing particle wear into the humerus. So this is an example of an early shoulder replacement with failure of the glenoid, and you can see on that picture on the right kind of the wear pattern through the plastic that happened pretty rapidly because of the instability of the ball against the socket. So in the mid-2000s, Dr. Walsh, who's a very well-known French surgeon, really defined kind of the morphology of the glenoid and the ball's relationship to the glenoid kind of preoperatively in arthritic patients, and saw that this kind of second column, the B class, was classified by subluxation of the humeral head, which is basically a partial dislocation of the ball posteriorly. And you can see, especially on this B2 glenoid, where the patient has not only posterior subluxation, but has started to wear through the back of the socket. This is something that we now very commonly see. and until then wasn't very well recognized. And when he looked at those patients and how they did after a shoulder replacement, and he is truly a master surgeon, he found 2/3 of his patients were not satisfied. I'm sorry, only 2/3 of his patients were satisfied. 20% demonstrated glenoid loosening with 6-year follow-up, and there was a 16% reoperation rate, which is clearly unacceptable. So this is an example of his a preoperative B2 glenoid and the subluxation that he saw postoperatively on CT scan. So while our goal is to restore anatomy, when the native anatomy is not good, like a knee like this, what your goal should be is to actually improve the mechanical axis. So we do a similar thing with the shoulder. And one of the really exciting things that we're able to do now is take CT scans of the shoulder, render 3D images. I take these CTs home, do the 3D imaging on my computer at home, and I'm able to basically plan a shoulder replacement, including the sizing, positioning, basically every kind of little detail to a T, weeks ahead of actually doing it. So this is one of my cases from a few weeks ago where this patient had actually 20 degrees of retroversion. So he had significant posterior wear, large osteophytes or bone spurs, obviously on the humeral side that were dealt with. But what I planned for him was to use what's called an augmented polyethylene component. So this is a glenoid polyethylene component that has a buildup in the back. And what we're trying to do is to restore the bone loss with plastic. We've tried to bone graft in the past, and especially with anatomic shoulder replacement, that didn't do well. So we now think that this is the most reliable way to not only build up that bone, but also this corrects the patient's subluxation. So there are now mid to long, I'd say midterm studies between 2 to 5 years that have shown very good results with this technique. So based on that computer kind of planning that I do, I will kind of pick 4 spots on the glenoid, and the computer generates this little guide that will guide that red center wire, which is where basically the glenoid component is based off of. They'll then manufacture this guide specifically made for this patient based on the patient's CT scan, and I'll have that ready, sterile for the surgery, and actually use it on the patient to apply that first guide wire, which again is where kind of the final position is based on. So in the native shoulder that has a large rotator cuff tear, patients can sometimes progress into something called cuff tear arthropathy. So, with patients in the past that had rotator cuff tears or rotator cuff tears with arthritis, there wasn't really a great answer for what to do with them. These patients had progressive superior migration. They would develop acetabularization or femoralization, which is basically acetabularization is forming a socket on the acromion because the ball is wearing up against it, as seen on the left. And femoralization is basically the kind of erosion of the proximal humerus into looking like a femur because it's wearing into that socket. With advanced changes, patients would get static superior migration, so the ball remains in a superior position, and they would also demonstrate anterior superior escape. So again, going back to those rocking horse phenomenons, if you try to put a total shoulder replacement in these patients, they wouldn't do well. So these are, again, the radiographic kind of changes that you would see with worsening what we call cuff tear arthropathy or rotator cuff arthritis. Favard also looked at the glenoid side and the different changes that you can see on the glenoid with cuff tear arthropathy. These patients are more likely to have superior wear of the glenoid because of that superior migration of the head. And especially in the E2 and E3 patients, you have to recognize if there's more bone loss superiorly, and you have to be ready to recreate that in order to get a good reconstruction of the patient's anatomy. So in the 1960s, surgeons tried to develop an answer for the cuff tear arthropathy patient. And so what they designed was the early reverse shoulder replacement. So what this did was first reverse the shoulder orientation, so put the ball on the socket side, but this was a constrained design. So the curvature of the ball matched the curvature of the socket. So there would be no more play between the ball and the socket. And essentially what they tried to do was to bring the shoulder back down. And actually what it this design ended up doing was lengthening the deltoid, as we'll show later. These designs unfortunately did not do well. They didn't have adequate stability at the glenoid, and so the ball would essentially loosen and lead to catastrophic failures. So the reverse was abandoned for many years, and it wasn't until Dr. Grammont in 1987 developed his reverse prosthesis. So his prosthesis worked because it was one constraint. So again, the radius of the curvature of the socket matches the sphere. Two, the deltoid was distalized. So if you look at that figure on the left, the position of that greater tuberosity has now been lengthened. And so the deltoid has been put on stretch and actually given a mechanical advantage. But where this prosthesis improved on the previous designs was that it medialized the center of rotation. So compared to this design here, where if you look at that center of rotation, the center of that ball is quite a far distance away from the glenoid. The newer center of rotation is now at the face of the glenoid, and what that does is it diminishes the force or the torque that the implant sees at the glenoid and basically increases the stability of it. So this is a prosthesis that is still used today. It's had about 20 years of follow-up with actually good results. So it was FDA approved in 2004. The usage of the reverse has only exponentially increased based on every basic time period that we've looked at, and the indications have expanded. So the cuff tear arthropathy is still the #1 indication for a reverse, but we're now doing reverses for irreparable rotator cuff tears without arthritis, complex proximal humerus fractures, severe glenoid humeral bone loss, and also for shoulder instability. One of the trends now, though, is lateralization. So there is a holy grail of this anatomic reverse replacement that we are trying to slowly get back to. Again, taking into account the early failures and the success of the Grammont, the current trend is to gradually add lateralization. So again, if you look at the center of rotation of the humerus in the native configuration, it's right there. It's in that center of that circle. And the native humerus has a lateral humeral offset. So that lateral humeral offset distance is about 56 millimeters on average. This is compared to the Grammont, which has the center of rotation now at the face of the glenoid and very little lateral humeral offset. The trend now is to lateralize, especially at the glenosphere. So if you look at this kind of a lateralized glenosphere prosthesis, the lateral humeral offset has been restored. The center of rotation is now some distance away from the face of the glenoid. And what that does is it increases the deltoid tensioning without distalizing the arm oftentimes. And this can also be helped by changing that neck shaft angle. So on the right, you can see 135-degree positioning of that polyethylene liner compared to 150 degrees on the left with the standard Grammont prosthesis. This also helps to tension the residual rotator cuff. So this is kind of an axial or bird's eye view of the shoulder. And on the right side, with the lateralized glenosphere, you can see that the posterior rotator cuff muscles seen on the bottom are better tensioned than the muscles on the left with the more standard or Grammont style glenosphere. And this has actually been shown to increase the patient's external rotation ability by better tensioning the posterior rotator cuff muscles, which of course is a very important function for patients to have. Another complication of reverse shoulder replacement is notching. So there was in the beginning some controversy about how serious a thing it is, but it's now pretty much consensus that it's bad. And what notching is that with improper positioning, you can get abutment of that medial humerus against that bone at the inferior glenoid. And with that abutment, you can actually get wearing of the way of the bone to the point that the glenosphere can loosen. So some strategies to avoid that are to avoid superiorly tilting the glenosphere, putting it kind of inferior so there's not a lot of bone kind of for that medial humerus to abut against, lateralizing the glenosphere in order to kind of get the humeral component away from that glenoid. And then again, also the 135-degree prosthesis seems to be better with as far as preventing notching than the 155-degree. So very commonly I get asked, how long is this shoulder replacement that we're talking about going to last, doc? Patients have all sorts of stories from their family members who, unfortunately, oftentimes the kind of conception is that shoulder replacements don't last very long and that we're not doing any of them compared to the hip and the knee. Um, Best data we have as far as anatomic total shoulder arthroplasty is from the Mayo Clinic. This was actually a previous generation shoulder replacement, so that's why we have 10 and 20-year follow-up. But at 10 years, it was 97% and 84% survival at 20 years. When you look at the reverses compared to the anatomics, very surprisingly, at 8-year follow-up, the reverses have less complication rate than the anatomics do. For you therapists that have kind of treated the reverses, I've definitely seen that the reverses get better faster. There is some thought that with long-term results that there is some deterioration of function, especially with the Grammont style, and that was shown by Dr. Walsh in his minimum 10-year follow-up study. But again, those patients had 93% survival. So while there isn't a lot of long-term data on reverse shoulder replacements, the midterm results are quite encouraging. So thank you for tuning in, and Clint and I hopefully will be happy to answer some questions. And again, I thank you for tuning in, and thank you for everything that you do for our patients. And please feel free to reach out to me at any point if you have any questions about my patients or any shoulder arthroplasty patients. Thanks very much.